complex joint. You're not just dealing with the glenohumeral joint in isolation. The shoulder consists of the glenohumeral joint. You have scapular motion. You have the acromion. You have the AC joint, the SC joint. You have you have the biceps involved in the technical sense because you have biceps tendon, which runs through the bicipital groove. So when you examine the shoulder, you have a lot to look at. The considerations are, is somebody's pain right here? Let's say somebody does have pain right here. What is this from? Is this from a shoulder pathology? Is this from a bursitis? Is this from a radiculopathy from the neck? Is this referred pain from the facet joint? Is this coming up myofascial pain from the trapezius? You have no idea. So that's what we're going to find out. So shoulder, same thing, and we'll the same thing for any other physical exam: inspection, palpation, range of motion. You would want to do skin-on-skin palpation, just like we did for the cervical spine. So we'll skip that step. Range of motion is important. Remember that you're primarily looking at flexion, extension, internal rotation, external rotation, abduction, adduction. You can do that actively, meaning the patient does it with their own strength, or passively, meaning that I'm going to do it and they're going to passively sit there. And we're going to test active range of motion here. So can I see you put your arms behind, your right arm behind your back like you're being arrested? So that tests internal range of motion. Internal rotation. Can you, just to test strength while you're here, can you push off your hand against mine? Try to lift your hand actually off the back. There you go. Great. You can stop. Can I see you flex your, and you're going to want to compare one side to the other. So flexion. So can you do adduction? Can you cross, just try to hug yourself, both sides? So that's adduction. Can you do abduction, which would go to 180 degrees? Nice job. You can do that too. I'm going to isolate internal and external rotation just a bit now. So what I want you to do is put your elbow, tuck it into your side, right into your ribs there. There you go. Nice job. I'm going to hold his shoulder, and I'm going to ask him just gently take the back of your hand and push against mine. That's external rotation. And now, conversely, can you bring it in? Internal rotation. You would compare side to side. If you recall, the supraspinatus tendon can be impinged between the acromion and the head of the humerus. So we have two tests that we're concerned with for impingement. One would be Hawkins maneuver. We're going to do internal rotation with slight adduction. This is about 45 degrees. If I don't stabilize, he's using his body to counteract any sort of pain I'm causing. This is reducing any force I'm actually putting at the shoulder, at the acromion where I'm testing. So I always want to stabilize, and this way you can see I'm isolating now as opposed to letting him use the rest of his body to compensate. So that's Hawkins maneuver. I like Neer's maneuver, which is shoulder flexion. I add a little bit of putting your thumb down. Hold that right there. Does that cause any pain?
No.
Okay, and you can do that. That can just be done actively. It doesn't need to be done passively. Next, we want to test the you can put your arm down. We want to test the rotator cuff muscles. That would be strength testing in all the activities we saw before. So your internal rotation, again, if you put your hand behind your back like you're getting arrested, push your hand off. There's strength for that. Can I see you actually, we did external rotation, so we didn't have to do that. So let's just see you do empty can test. So put your arms out 45 degrees, thumbs down like you're pouring out 2 cans of soda. And I'm just going to press here. This test primarily supraspinatus. You're nice and strong. So I'm happy there. You always want to palpate in the area of the biceps tendon. So arm out, and I just want you to raise. Excellent. And then Jurgensen's is off to the side, right? Yeah. So actually, Jurgensen's, can't they just do it straight and then supinate here?
Oh, you can.
Yeah.
That's what I learned.
Let's try it here. So put your elbow in, onto the biceps tendon, and then supinate. Supinate against resistance. Excellent. Okay, elbow. Same thing. Inspection, palpation, range of motion. I'm just looking. I don't see. Remember, elbow. One thing one of your differentials is crystalline disease, right? So make sure you do palpate the elbow, because more often than not, you're going to see some large, big, swollen, red elbow. It could also be an infection, but sometimes you'll just, have some form of gout or pseudo gout, and if you do aspirate it, you can send the crystals for analysis and treat from there. So you definitely want to inspect, compare one side to the next, palpate, medial epicondyle. Remember, we maintain anatomic position, so you have your medial epicondyle, and then your lateral epicondyle. If you were to have lateral epicondylitis, you have, another name would be, strong word, medial would be? Golf. Exactly. So that's why taking a history, as with everything else we've done, is vital, because as someone is an avid golfer, you kind of have some place to start to kind of focus your exam. Remember, there are ulnar side collateral ligament and radial collateral ligament as well. There's no harm in palpating and taking the joint through its range of motion. All right. Can I have you? We're going to test the extensor compartments, which tests the muscles for which will bind at the lateral epicondyle. So I'm going to have you extend your wrist against resistance. You can see how this is actually the extensor compartment's flexing here. Nice job. Turn your hand over and flex against resistance. Nice job. I'm going to have you, now I'm palpating the condyles here. I'm going to have you supinate against resistance, and then turn your hand over, and then we'll have you pronate. Oops, hang on. Pronate against resistance. Now, people might be tender, so you have to bear in mind when you ask them to do that, you can achieve the same goal by holding it in the wrist if they have tenderness in the hand. Let's say they have a broken hand or rheumatologic disease, but you still want to test, right, because they've had some trauma. You can grab down here. Conversely, if people have wrist pain, you can try to hold either higher up the arm or lower. All right, so let's have you pronate against resistance. There you go. Nice job. Hand, what you're primarily looking at is rheumatologic disease. While you may think that may not relate to the spine because you're looking at a hand, in case somebody has sacroiliitis or ankylosing spondylitis, your first clue might actually be nodules in the hands, redness, swelling, erythema, which I don't see here. All right.